morning. We are now to do an interview to the Dr. Maria Sameiro from Hospital Oporto in Portugal. She is a doctor that dedicates to ambulatory procedures doing in phlebologic pathology. And we are today to talk about the office-based procedures.
Yeah. Thank you, Dr. Lourdes Reina, for this interview. I am happy to be here and thank you for have the opportunity to talk about my practice in office-based setting for phlebologic procedures.
Good, Mary. I wanted to ask to you what type of procedures you think you can do in an office-based setting?
I think the main reason to do the procedure is to do it under local anesthesia. So if we can do it or we don't, not with anesthesia or local anesthesia, we can do it. So mainly all the procedures except endovenous procedures, except the ones that need general anesthesia or epidural anesthesia, like stripping. That's the one that we cannot do. I think that other procedures that need local anesthesia and sedation, that can be a problem, like laser procedure, because the pain. The pain is the other reason for not doing the office-based procedure.
So you do radiofrequency?
Yeah, I do radiofrequency, I do mechanical, chemical ablation, and I do cyanocrylate for procedures. That's the one I are in my public practice and in my private practice. Actually, I just cannot do the cyanocrylate yet in public practice because it's very, very expensive, the catheter.
And do you do these procedures with a special security protocol, different from the operating room protocols?
No, I think the more safe protocol is the one that we do in the operating room. So why don't do the same? I think in my office-based practice at the public hospital, we do the cross-check just like we do in the operating room. So we can do it all. And I think the importance of the endovenous procedures is that we can do them guided with ultrasound, so they are safe at any time because we are always cross-checking. More than when we do a stripping procedure.
Yes, they are different procedures.
Yes,
yes,
they are.
And another question, Maria, where is it the operating or the office? Inside a hospital or outside a hospital?
Well, I have the two things. I have in my private practice. I just work in a building that there is many offices, and not all the offices are of medical clinicals. So I just, when I do the procedure, I have an anesthesiologist that works with me, and I have like a small bag with every emergency things that we need for if we have an emergency. So we are prepared to do all the survive procedures with an anesthesiologist. In my public hospital, I just don't have the anesthesiologist inside the room, but I have them in the building. So it's just this distance of a phone call, and sometimes in one of the rooms that we work, we have the anesthesiologist just the other side, the other door.
So, Marie, and what was the challenge of building your endovenous office based at a public hospital and at your private practice?
The challenge I have is to make my hospital understand that I need to the advantages of changing from the operating room to the office space, and the most advantage is economic. The costs low a lot without in two ways. In the way that the patient does not need to be recovering from the procedure for many days, so he can work the other day. So the time that he was not working, that he is not working, is very low. And the other thing is to change from it's not use so many human resources, and we can just lower the costs of the personnel that is involved in the procedure. I just have a nurse and myself. Sometimes I have a resident just because he is training, but not for the procedure. So I just need to be myself and one other person, and it lowers the costs a lot.
It is a really advantage and cost. And also I think that the patient will will ask for these ambulatory procedures.
Sure. At this time of financial crisis, I see in my private practice especially that mostly, for instance, the teachers, they work for the public, and they need not to work. So they just ask me, can we do it ambulatory, strictly ambulatory? Can I go? And there is another question. Sometimes the patients they need to exercise, because people is knowing that they need to exercise, and to know that they are not going to stay for 15 days without doing a lot of exercise. It's good. Even though one of the things that I do is that every intravenous procedure, people has to walk immediately after them. So that's good even for the psyche of the patient.
Yes. And what about the reimbursement with the insurance company? Do you think they have to change their mind?
Yes, that's my main difficulty, is to get the correct reimbursement, to make people think that in spite the fact that we change from the operating room to a simple environment setting, it does not mean that the procedure is less challenged for the surgeon. It means that it's more difficult, because we have to have. I got a big learning curve to get there, to be able to do the ultrasound at the same time I do the procedure. That was an investment that I have to do, and so and during the procedure I'm always. I have to be very concentrated. It's quite different from doing a stripping procedure that we learn at the beginning of our practice, and it's not guided, so it's not so complex. I think endovenous procedures are more complex, and the insurance company don't want to pay that,
I see. Mm-hmm. Okay, thank you very much.
Thank you very much.